Welcome to the latest episode of MQ's podcast, Open Mind. This afternoon, we're delighted to welcome our latest guest, Professor Allan Young. And Allan holds a chair in mood disorders and is director of the Centre for Affective Disorders at the Institute of Psychiatry, Psychology and Neuroscience at King's College London. So welcome, Allan. Thanks for joining us on our podcast.
Thank you, Rory, and thank you, Craig, for inviting me here today.
Oh, welcome in.
Yeah, so we're really interested to see such an important topic that you've spent many, many years researching, is trying to uncover and understand mood disorders and its causes, and in particular bipolar disorder, where we focus on today, and also the treatment for bipolar disorder. But before we get into those details, Allan, what would be great is we're always keen to hear about people's journey in mental health research. So obviously I can detect, as I'm a brilliant scientist, your Scottish accent. So can we start with, tell us a bit about where you're from and how you got into psychiatry and mental health more broadly, and how you've got to now in, obviously, King's?
Well, thanks very much, Rory. So, I don't come from a medical family. In fact, I think I was the first person in my family to go to university. But at high school, I was good at sciences. And if you were good at sciences, they tended to want you to take a punt to medicine. And so I did. And so I got into Edinburgh University. And I actually, quite frankly, found the first few years quite boring. Perhaps that's a bit harsh, but, certainly doing anatomy and so on didn't really excite me. But I really liked it when we got into the clinical years. And I did a sort of road test with all the subjects, because when you're a medical student, you do surgery, GP, this, that, and the other. And I actually focused on the brain, and thought that the bit I was interested in was the brain and brain disorders. And neurology just didn't seem very interesting or exciting because, essentially it wasn't. And there weren't many therapeutic prospects. But psychiatry, the Department of Psychiatry at Edinburgh at that point was really very strong. I'm not saying it's not strong now, but my experience as an undergraduate was it was quite inspirational. So I thought I would think about going into psychiatry and thinking about doing neuroscience research. And so that's how I ended up there. When I initially trained, I did my first postgraduate degree in brain imaging and schizophrenia, which was the 80s. Mm. And I did that with Professor Douglas Blackwood. And then I had the chance of doing a fellowship or going for a fellowship with the Royal College of Physicians of Edinburgh. And Guy Goodwin asked me if I wanted to do it in mood disorders with him. So I switched about 89, 90 into mood disorders. And I must say, I've found it personally a very rewarding field to work in. And I've worked in it in Scotland, England, North America. And I came to the Institute of Psychiatry, Psychology and Neuroscience about 10 years ago, and I set up the centre. One of the reasons for coming to King's, because I was at Imperial, I was chair of Psychiatry at Imperial, which of course is a fantastic university. But King's gave me an opportunity to do two things which were perhaps lacking elsewhere. One was very much get involved in the clinical side with the National Affective Disorders Service and set up a specialist service for bipolar disorder, which with colleagues I did. And also we established a master's in affective disorders. Now, lots of academics, look upon teaching as being perhaps something that's slightly less prestigious or rewarding than research. But in actual fact, I think there's a virtuous cycle between teaching and research. And I must say, having set up the masters and teaching on it and still teaching on it, I've learned a huge amount from having to communicate about my field to young, very bright students from all over the world. So I found it very rewarding.
No, I think the point you make there about whatever the virtuous cycle between teaching, especially I would argue postgraduate teaching and research, I think there is a real synergy. And I think it's great to see the university sector in some way now, I would say only in the last 5 or 10 years, starting to more reward more that more teaching informed research, I suppose, approach with the growth, I suppose, in master's programs. But as you say, it's always a balance. But I want to bring you right back. So did you tell me where you're from in Scotland, though? I don't think you did you?
Well, when I say where I'm from in Scotland, people have never heard of it. And when I say that, people then say, of course I'll have heard of it because I'm from Scotland. But I come from Clackmannanshire, and I come from a place in Clackmannanshire which is called Glendevon. And in actual fact, within that, I don't actually come from anywhere because my father, who's passed away, was a farmer, and so we, there wasn't a town or a village. We were a few miles. So I really come from nowhere. But the closest place that you can say I'm from is Glendevon or Clackmannanshire, and most people in Scotland have never heard of that.
I've never heard of Glendevon. Did you say Glendevon?
You never heard of Glendevon? It's got a lovely, and it was actually the lowland stronghold of the Campbells. And there's a nice castle there. You can go for a nice walk and look at it. It's very, and you can see, can't quite see Glasgow. You can see Fife, Edinburgh, the Lothians, the Forth from the top of the hills. So.
No, I know Clackmannanshire, but I don't know. So it's
it's the River Devon that goes through it.
Yeah.
The surrounding glen is Glendevon. So there you go.
Well, I'm glad we got to the bottom of that. Because it was just curious you hadn't noticed it or hadn't mentioned it. But then, of course, then it's not part of your identity. Then, or less of it part of your identity if you're saying you're from nowhere. So they're a bit of psychology.
Oh, no, I don't personally feel I'm from nowhere. I do feel I'm from somewhere, but I'm not from. The farm was a farm, so it wasn't a town. Our nearest town was maybe where I went to school first. Was about. I think 3 or 4 miles away. So
anyway, I digressed there. So Alan, so sorry about that. Let's bring us back on focus then. So you obviously lead up the Centre for Mood Disorders, but today maybe it'd be great to talk about bipolar disorder. But first of all, maybe start with what is bipolar disorder? How common is it? Obviously a bit about the history even of the definition of mood disorders, bipolar disorder over time. It'd be great to hear about that.
Well, first of all, you may have noticed that I'm the professor of mood disorders, but I'm director of the Centre for Affective Disorders. And those two things are not quite synonymous. And the mood disorders is perhaps more North American. And I think the problem with mood disorders is it tends to hang everything on mood. So if you look at episodes of depression, for example, there are two hallmark symptoms, anhedonia and low mood. And you've got one of those two. But you can have anhedonia without endorsing low mood. And many groups are unlikely to do that. In this country, elderly people, and particularly people from East Asia. So when I worked in Vancouver, which I did for 6 years, I had lots of people from China, first, second generation, and they would present with severe depression, but they wouldn't say that they were depressed. So that's why I to some extent, hedged my bets with the two names. But also affective disorders is somewhat of a wider thing. And some people would include anxiety disorders, some anxiety disorders within it. So what are mood disorders? Well, they are a very common condition in adult mental health. And if you look at the burden of disease, really major depression and generalized anxiety, which are pretty closely allied, are the biggest category. And then you've got things like bipolar disorder and schizoaffective, and then you've got all the other things which are secondary mood disorders. The key definition where we start off with is probably recurrence. So if you look at first episode of depression, this was beautifully done in Baltimore and reported on about 15 years ago. They looked over about 3,500 people with a first episode of depression, and they followed them up for over 20 years. And they found that 50% didn't have a further episode. The other 50% were a mixture of recurrent or very tragically unremitting depression. So immediately this suggests that the people who have one episode and nothing else, which must be quite common, it's a different experience. And I often think this is akin to adjustment disorder or a reaction. It goes back to the old notion of reactive depression and endogenous depression. I think we run into lots of problems if we use those labels. But if we think about single episode versus recurrent, then we're on far firmer ground. And indeed, the great European psychiatrist Emil Kraepelin said that one of the first things you had to determine with a mood disorder was whether it was recurrent. And indeed, my old unit in Newcastle, where I worked for 10 years, very happily, was called the Recurrent Affective Disorder Service, because that's what it was all about. So if we get into recurrence, that means that what we might call unipolar depression, where you just have depressions, and bipolar, where you have ups and downs, pathological episodes of moods in both ways, and also mixed episodes, you can see that there's a commonality. And indeed, they were both included in the old concept of manic depressive illness, which included people who'd never been manic, but only had recurrent depressive illness. So I think one of the problems we have in perhaps life in general, but certainly in mental health and psychiatry, is siloing things, perhaps siloing things inappropriately. And I think cutting depression off from bipolar disorder is wrong for a number of reasons, not least of which is the fact that people who are unveiled as bipolar will very often have a couple of episodes of depression first, with no real categorical way of saying that they've got bipolar. So inappropriately siloing knowledge, services, and so on is wrong, I think.
And that's really helpful. But thinking then, I suppose, from my point of view, from a researcher into suicide, we know there's a differential mortality rate, for example, associated with people with bipolar as distinct from major depression. And I suppose that I was very curious. You said, there's the challenge of siloization, right? I assume there are benefits as well, because the treatment development, in part of, I suppose, the mechanistic work initially is obviously we've tried to, I assume, as a field, focus in on particular phenotypes and then develop treatments specific to that phenotype, or to bipolar versus major depression. So is there a tension in between going down the siloized route versus trying to look at the commonalities or a sort of common features?
Much of our research at the Institute is about trying to look at personalized medicine approaches and to actually look at biomarkers and subtypes. But I think if you don't actually have that, it's probably inappropriate to do it. Now, the problem with major depression goes back to, I think, 1980 and the introduction of DSM-3, which was really masterminded by the great Bob Spitzer from Columbia in New York. Now, there was lots of really good things about DSM-3. I was a medical student when it came out, and I was in North America. And I remember palpable excitement amongst the psychiatrists because they had this manual which gave them reliable diagnoses. And indeed, if you look back at the literature at the time, it was getting them up to the same reliability as, say, cardiologists with heart sounds and things like that. But there have been criticisms of the DSM-3 concept of major depression. There's a wonderful article by Professor Ed Shorter from Toronto as a historian, where he says that basically major depressive episode is too big a bucket with too many different things in it. So contrary to what you're saying about looking at different phenotypes, everything was poured in there, including melancholic. It's very often forgotten that major depressive episodes occur in both bipolar and unipolar. So it's called, you can have a major depressive episode, but not in major depressive disorder, in bipolar disorder. And then you've got atypical, you've got anxious, you've got this, that, and the other. So I think Ed Shorter was right, but I think DSM-5, which came out in 2013, which was criticized and found wanting by lots of people, I think it addressed, to some extent, this with major depressive episodes by having specifiers. So you can apply specifiers which really subfractionate major depression. I think that is an advance. We haven't seen many trials using it because there haven't been that many trials, for example, by pharma companies of new treatments, but it is actually a very interesting way forward. We've seen at least one concrete example, which is a trial by my friend, Professor Tricia Suppes from Stanford, who did a trial of an antipsychotic in major depressive episode in MDD, but with mixed features. Now, this is a curious concept. So you don't have bipolar disorder. You've ruled that out, but you've got a major depressive episode and you've got some mixed features, which are essentially some of the signs of mania or hypomania. So naturally, people like me think, well, that's pretty close to bipolar or manic depressive illness. Now, Trish did a trial of antipsychotic called lorazepam in this. And it was interesting because it was significant, but also it separated very markedly from placebo. And one of the great problems with all of the trials in this area is the high placebo response. And so it suggests that if you can tailor the treatment to a particular subgroup, then you might get more of a drug placebo separation, which I think is actually very important. And we need to follow up on that, actually, and think about that more.
Well, we'll come back to that in a second then. But so go sort of circle back a bit to the diagnosis issue. So am I right in thinking that bipolar disorder, the duration from presentation to getting the correct diagnosis is greater than some other mood disorders? And if that's the case, what can we do to improve that? And what are the reasons for that?
Well, I mean, this came out in the Bipolar Commission, which Bipolar UK just published. Many people were involved in it. I think it's actually a very, very good piece of work. And it took the views of really hundreds, if not thousands, of people with bipolar disorder and looked at their experience across the UK. It's often said that the delay to correct diagnosis for bipolar disorder is about 10 years. Now, that's not the delay to any diagnosis, it's the delay to the correct diagnosis. Mm-hmm. We found in the Bipolar Commission it's actually 9.6 years in the UK. So that's pretty much as bad as we expected. Now, there's a number of reasons for that. One is that bipolar disorder doesn't necessarily fully unveil itself immediately. So there may be childhood antecedents, there may be an excess of things like anxiety disorders, there may be ADHD in some subgroups of individuals who go on to develop bipolar. Then in teenage years, there may be mood lability. We found recently, we published a review finding that mood lability, which was your mood going both ways, is actually one of the strongest predictors. And then there may be isolated symptoms. And then there may be one or two episodes of depression. There may be substance misuse, alcohol misuse. And all of these things may be mislabeled. I mean, bipolar disorder is most commonly mislabeled as major depression. Mm-hmm. Or personality disorder. I mean, I've had patients refer to me where it's been said that they've got depression with emotionally unstable personality disorder, when in actual fact they had a mixed affective state. So I think part of the delay in the diagnosis is due to the nature of the disorder and the fact that it reveals itself sometimes quite slowly and it overlaps with other disorders, but also awareness of bipolar disorder, both in the general population and unfortunately in many parts of the country in healthcare professionals is quite low actually. And I've been privileged usually to work in places that are specialist centres for mood disorders like Oxford and Newcastle. But when I came to London, I was really quite shocked that clinicians just didn't really consider bipolar disorder. So I think there's a big educational task ahead of us. And that was part of the motivation for the Bipolar Commission.
And so in terms of the prevalence, what is it, 1% or so in the general population?
No. I mean, first of all, bipolar disorder isn't one thing. One may think of it as in three ways. Well, first of all, there may be organic secondary mania, which isn't bipolar disorder. And we think there's a lot of that in low and middle income countries. But bipolar disorder proper has got bipolar 1, which has got mania, and usually depressions, but not always. You do get unipolar mania. Bipolar 2, when there's hypomania, which is a lesser form of mania, which in and of itself is not particularly severe, but the depressions are just as bad, if not as bad as bipolar 1 or major depression. And then you've got subsyndromal, where you've got full-blown depression, but you don't quite make hypomania, or you've got hypomania, you don't quite make full-blown depression. Now, my view is that the best epidemiology was done by my friend, Dr. Kathleen Merrick-Angus in the United States, who did a community survey of about 10,000 people and found that the lifetime prevalence of bipolar 1 was about 1%, bipolar 2 was about another 1%, and subsyndromal was about 2.4%. So it adds up to over 4%. Most people would say that, let's just look at bipolar 1 and bipolar 2. That does seem to be about 2% lifetime risk. And that was confirmed. I don't think there's data for Scotland that I'm aware of, but the English National Mental Health Survey showed about 2% for bipolar disorder. So it's not uncommon, really.
Mm-hmm, yeah. And then go back to your point about the delay to diagnosis. So what can we do then to get that whatever 9.6 years I think you mentioned in England to shorten that time period, or is it just inevitable?
No, I mean, Bipolar UK went throughout the UK. In actual fact, you might be pleased to hear that the best performance was Northern Ireland, where it was only something like 9.3 years. But then that was only based on 100 people, whereas there was
Yeah.
bigger samples in other areas. So I think it's pretty poor anywhere. Well, I mean, the first thing we decided is that we shouldn't go for 0 because that was unrealistic. But we decided to say that we should be going for reducing the delay to 5 years within 5 years.
Mm-hmm.
Now, it must be said that people with lived experience are different in different groups. People with bipolar disorder are actually very keen on an accurate early diagnosis. That's different from other groups of people that suffer from other mental health disorders, and not all of them, of course, but some of them. But people with bipolar disorder want an earlier, more accurate diagnosis. So I think, first of all, we've got to highlight it. That's what the Bipolar Commission was all about. Publicizing it, things like this podcast will hopefully be quite useful. And then educating everyone, including mental health professionals and the general public about it. And, hopefully change will happen.
Yeah, and I assume the earlier diagnosis is associated with better outcomes in the longer term.
Well, that's an interesting question. I'm not sure anyone's definitively shown that, but certainly anecdotally, you hear people say that, for example, one thing is that antidepressants are very commonly used in bipolar disorder to treat the depressive phase. There's almost no evidence that they treat depression effectively. So the biggest study was done by myself and Susan McElroy from Cincinnati with the drug company AstraZeneca, who were interested in their drug quetiapine. But we did a comparative study we did 2 studies, one of which involved lithium, but the other one involved the SSRI paroxetine versus placebo versus quetiapine. And the quetiapine separated from placebo, reducing the bipolar depression. The paroxetine didn't separate from placebo. And that's the biggest study, and that included bipolar 1 and bipolar 2. It did help a little bit with anxiety symptoms. So the first thing to do is to base your treatment on the diagnosis, not on the particular mood episode that the person's in.
And so what do the NICE guidelines say, though? I'm unfamiliar with what is recommended treatment then for bipolar?
Well, I mean, the thing about bipolar is it's not as simple as recommended treatment because you've got different phases. You've got mania, hypomania, mixed symptoms, bipolar depression, and then you've got acute treatment, continuation treatment, and maintenance treatment. One very good thing about the NICE guidelines is that they really highlighted lithium as a first choice drug. And the BAP guidelines do that too. So do all the international guidelines I'm aware of, including the Canadian World Federation. We actually just did a systematic review of this, which we just published this year. It was done by one of our very bright MSc students, myself and a few colleagues. And we actually looked at all of the outcome measures for treatment with lithium, because previously people just looked at mood symptoms or whatever. And if you look at all of the outcome measures, about 50% of people on lithium in trials do well or very well. And that's across the board. Of course, the other 50% don't. And therefore, the question arises as to how do we choose the 50%? That goes back to your question about personalizing medicine. Yeah. So we have a big 15-center project funded by the EU, which is headed by my friend in Paris, Professor Franck Bolivier, and we've been very instrumental. People in Newcastle are doing it. And this is looking at the biomarkers of lithium response. So I think this is the way forward, trying to work out which people will respond particularly to which treatments. Yeah. Because that's what's worked in the rest of medicine.
And then what about then? So what is the evidence for, or is there evidence for the psychosocial interventions or the combination of psychosocial plus pharmacological? And I appreciate, obviously, depending which stage of the disorder you're talking about.
Yeah, well, I mean, I think one thing that has happened over the past 20 or 30 years is we've allowed the different aspects of the treatment approach to get divorced from each other. And I think, you shouldn't be looking at drugs or pharmacotherapy on their own. They should always be combined, or at least controlled for in studies. So what you might call the psychotherapeutic or the psychological approach in bipolar disorder is extremely important. The best evidence, in my view, treatment is what's called psychoeducation. And that's really, that originally came from other branches of medicine. I think it originally started in TB treatment, but as did many psychotherapies. But the psychoeducation was pioneered by the Barcelona group, by Colom and Vieta. Interestingly, there's, a number of psychoeducational sessions that look at the nature of the illness, triggers, early warning signals, physical health, and so on and so forth. This has been shown to reduce relapse rate over a prolonged period. It's actually been shown to improve adherence to medication. One of the interesting wrinkles is that it's much better in a group format, which I think can be online. The work was all done before all the groups went online. And that's because it's not all about a didactic delivery of information, because in, of course, the group, people will get challenged by other people with lived experience. So in one of our groups, there was someone said, well, I just don't think bipolar disorder is a proper illness. I'm not taking these meds, And we very often find that the first few years, and sometimes tragically longer than that, of the illness, people deny they want to, not have it because they, it's somehow intangible, except when they get ill. But one of the other members of the group said, well, I'm bipolar, but I'm also HIV positive, and I'm on medication for that. If I look at the figures, the outcome for the bipolar is possibly even worse than being HIV positive now. So why wouldn't I take the recommended treatment for both? Now, that was a very powerful challenge, and it was much more powerful coming from that person than it would have been from the doctor, the nurse, the therapist, the psychologist, or whatever. So I think that's a bit of a clue as to why the group format. Now, there are some places where you can't do the group format. Some cultures don't necessarily want to have it. But I think psychoeducation is extremely important. It's best combined with optimized medication, which is what we do in our service. I think the other treatments, there's not a huge amount of research on them, but my view is that the other psychological treatments are perhaps best done in a bespoke way, more targeted to individuals who you think they might benefit. So a very good example is David Miklovitz, who's a friend of mine, Los Angeles, a psychologist that does work on what he calls family-focused psychotherapy for bipolar. And I never really understood this until I happened to sit up the back of a bus with David at a conference going to a dinner, and he explained it all to me. And essentially, if you're trying to do psychoeducation with a 16-year-old in Los Angeles, and you're saying you've got to have a regular routine, you've got to avoid destabilizing influences, this, that, and the other, and they're living in a household where no one is doing that, you've got to go in and intervene with the whole family. So David has got evidence showing that, this works in that particular context. Jan Scott did a great study of CBT in bipolar, which overall didn't come out as being effective. But if you look at the subgroups, the group who were earlier in the illness, who were more what you might think of being intact, especially cognitively, I mean with neuropsychologically, they seem to really benefit from it, whereas people further on in the illness actually didn't. So, and there's other things like interpersonal social rhythm therapy. I mean, we're doing some work with... Hold
on, what's that? I've never heard of that. Interpersonal social rhythm therapy.
Well, lots of people think bipolar disorder is very related to disruption of your circadian rhythm. Of course, when you get ill, your sleep goes off and so on.
I thought, Alan, I thought you said social rhythm when you said circadian rhythm.
No, well, hold on, I did.
Oh, you did.
Yeah.
Right.
I thought it had something to do with dance or something.
Well, yeah. Well, we've got a project with dance with Parkinson's, but that's another topic. But the one of the best triggers for, not the best, one of the most powerful triggers for people with bipolar disorder getting manic is jet lag. So years ago, they did a study looking at people who arrived at Heathrow and were manic. And of course, it's much more coming from the west to the east than coming from the east to the west. And that's because coming from the west to the east is much more disruptive. It's easier for us to have our days lengthened. So I'm sure you've noticed this, Rory, that when you go to a conference in America, it's a bit easier, to go there, but coming back is more disruptive because your rhythms get chaotically disturbed. So the group in Pittsburgh, and there's a great history of mood disorders research in Pittsburgh, which of course does have a strong link with Scotland, with Andrew Carnegie. Yeah, you'll know Rory. Ellen Frank and David Kupfer did something called interpersonal social rhythm therapy, which is all about regularizing your rhythms so you don't disrupt them and therefore, bring on an episode. And there's other work on early warning signals. Richard Morris from Nottingham's done a review of that. There's very good work showing that you can actually recognize the early signs of, say, becoming manic. It's much easier to recognize early signs of becoming manic than depressed, because people tend to sink into depression, tends to come up with them without them knowing. But with mania, or hypomania, we do a personalized signal, and it's the same things in different combinations for people. So for some people, it's more energy, it's less sleep, it's more spending. Some people become mildly paranoid, and so on. And I think one of the great ways we might be able to detect this in the near future is increased activity, as shown by Fitbits and so on. Mm-hmm. And if you do the early warning signs and you give people the option of starting medication on their own, you really do reduce the relapse rate. So I think the key thing is it's really a combination of these psychotherapeutic illness disease management approaches and judicious use of medication. Mm-hmm. The other thing that comes out incredibly strongly in the Bipolar Commission is the need for continuity of care. And this came out years ago in the Schizophrenia Commission that Robin Murray headed, that reported about 20 years ago. And there was one young man who, during an acute psychotic break, in 1 week had been assessed by 6 different teams. So, even if you weren't paranoid at the beginning of that, you certainly would be about halfway through. So people really value continuity of care. And of course, all of the health services and so on are stretched. But with the prospect of having digital approaches, then we may be able to enhance that a bit better. But that's certainly another thing that needs to be done.
Well, thanks for that. Thanks for that, Allan. Right, so we're quickly running out of time. We've another about 10 minutes, I think. So we'll try to squeeze a couple more things in. So this is sort of a bit back to front, right? Because we've just done the stuff on treatment, but we've touched a bit on sort of markers or risk factors and so on. But just curious, what in the last 20 years, what are the key developments, or what have been the key developments in our understanding of the mechanisms or the causes of bipolar disorder, in particular, as distinct from other mood disorders?
I mean, the first thing to be said is that there's been a great advance in the genetics in some way. Mm-hmm. Yeah. So genetics have gone much more to what we call the polygenic risk score, rather than single genes. So this isn't one gene causes bipolar, or one gene causes most of it. It's that there's a whole variety of genes. So I always think it's a bit more like height rather than eye color, because your eye color, as I understand, is relatively simple genetically, whereas your height's got multiple genetic inputs that also interact with the environment. So we've got this polygenic risk score. Nick Craddock, who is retired now, but led a huge Wellcome Trust collaboration, and we identified lots of genes with relevance in bipolar disorder, some of which may be related to mechanisms such as the calcium genes, which may be related to the nimodipine treatment that some people with rapid cycling seem to respond to. So genetics took a bit of advance. I think we've also seen the similarities and differences with schizophrenia. Now, you've got to go back to the 19th century. Kraepelin, who really formed the framework that lots of us still think in.
The second mention of Kraepelin in one podcast.
Yeah, well, Kraepelin. I wrote an editorial about DSM-5 called "Footnotes to Kraepelin," because really they've changed some of the names, but they haven't changed the concepts. Bipolar. Now, Kraepelin cut the whole psychoses into manic depressive illness, dementia praecox, which is now schizophrenia and bipolar. We know that there are differences with schizophrenia and bipolar, and the big thing is that most schizophrenia has a neurodevelopmental aspect, and most bipolar doesn't. So if you look at the Dunedin study, which looked at kids in New Zealand, the first decade of life, kids who became schizophrenic in the third decade of life were underperforming their peers on average, even at the age of 4 and 7. Kids who developed mania and bipolar disorder in the third decade were on average brighter. 2/3 of a standard deviation, 10 IQ points. So, of course, these are averages and there's overlap and so on. But, this is clearly a differentiating feature. So the neurodevelopmental aspect is much stronger in schizophrenia. Interestingly, the old Canadian work suggested that the bipolars who didn't respond to lithium had higher rates of schizophrenia in their relatives. So that's more allied to schizophrenia. So I think this neurodevelopmental aspect is key. We know that both groups suffer from cognitive impairment, but with bipolar, it's much more related to the episodes. And of course, copy number variants, which are a genetic finding, are present. Abnormalities are present in schizophrenia, but not bipolar. Nick Craddock reported that. So I think we're beginning to see similarities and differences, and I think the neurodevelopmental course is absolutely key. One of the big areas for therapeutic advance is actually understanding how our drugs work. And I've mentioned lithium. I mean, lithium is 4.5 billion years old. It's an element, not a drug. And it does seem to be effective. It's never had a drug company market it. It's catastrophically underused. It reduces suicide rates. It really helps long-term outcomes. But I think if we could revitalize it by saying to people, well, before we did this research, we could say you have a 50% chance of responding. We can now say you've got a 90% or indeed a 10%. That would really increase the uptake. We're doing lots of study about cognition per se. So I've teamed up with my very good colleague and friend, Professor Dane Till-Wykes, who's got a project, a modality for treating cognitive impairment in schizophrenia called Circuits. Now, there's certainly evidence to show that Circuits helps cognitive impairment in schizophrenia, which is quite remarkable given the neurodevelopmental nature of much of that. But our little pilot study showed, until I'm sure she would not be offended by me saying she was quite startled, that the therapeutic effects were so great in bipolar. And we're now following that up with a big study across England to look at cognitive mediation. Has to be done when people are not in an episode. But it's remarkable how people with bipolar disorder responded in our first study. So I think there's lots of traction here. There's lots of other things we should be thinking about, such as comorbidities. But I actually think we could go a long way by just applying current knowledge and treatment packages as well as we could. One of the things which drives me nuts, if I'm allowed to use such a term, is the fact that the NHS, at least where I am, maybe different where you are, Rory, tends to think of episodes and not the person. And so we're continually told that you should be discharging the person after their episode of mania, and then they can go on. Then they'll come back if they get manic again. Now, we looked at this, and we found about a couple of hundred people in our part of London who got admitted repeatedly with manic episodes. And we found they were being discharged after about 30 days in hospital, very often straight back to the GP. So we instituted a 12-week package with psychoeducation, tailored medication management, advice about sexual health, physical health, everything. And we reduced the relapse rate in that group by 80%.
Wow.
So, that's not rocket science. That's just applying current knowledge. But also it's going against this assumption that, the NHS should be dealing with things in discrete packets rather than tailoring it to the individual and their particular needs.
That's a great mention, because as you may have seen that we published a Gone Too Soon paper in Lancet Psychiatry earlier in the year. It was co-led by myself and Carl Worthman, and it was focused on trying to reduce priorities for action to reduce premature mortality associated with mental illness and mental distress. And we brought together 40 experts from around the world. But one of our number one messages is exactly that. It's that integrated healthcare, and so it's tailored, properly tailored, and lots of examples. You just given one of how that not only is it better for the patient, but also is cost effective and makes sense economically as well. So that means that was nicely timed that was an MQ led project. So that's why.
Oh, excellent! Well done to you and MQ. I mean, I must say that we're not going to return to fantasies of the past, where we had Sir Lancelot Spratt or Dr. Finley's Casebook or something like that. But I think a way of providing this continuity of care may come from digital approaches, and I'm very hopeful that that's a way of doing it. But I think our policymakers in NHS should think more about the people and the nature of the disorders that they suffer, rather than necessarily thinking almost in supermarket terms about little boxes that have got to be delineated.
Well, I suppose it's just taking a genuinely person-centered approach.
Absolutely.
Okay, let me try and throw in two quick ones before we finish, Allan. What's your aspiration? You've touched on a lot of stuff ongoing that you're involved in, but in terms of if you were given an unlimited budget, so to speak, and say if we invest in X, either in a mechanism understanding or a treatment, that would lead to a step change in both the understanding and hopefully welfare and well-being of people with bipolar disorder.
I spent the first half of my career thinking about mechanisms. I'm still very interested in them, but I don't have that much time left. So I'm now moving on to treatment because I'd like to make a difference. And I would like to see lots of therapeutic trials. But what I would really like is a bipolar treatment pathway. That now we have this. We have this in the Maudsley. We've got a bipolar treatment pathway that goes from detection right through to treating all the different episodes with different modalities: psychological treatment, psychoeducation, pharmacotherapy, neurostimulation, so on. What I would like to see is that would have more supporting evidence for each individual stage. So, for example, we know that clozapine helps treatment-resistant schizophrenia. A couple of very small studies showing it helps treatment-resistant bipolar. There's no decent trials in it. There's no decent trials of using clozapine, for example, in rapid cycling, which, you know, given how difficult rapid cycling bipolar is to treat, we need more studies. So we need more conventional science, but we need to build it into a framework of a pathway that goes from initial assessment, detection, right through to rehabilitation and helping people with their cognition and reintegration into the community and so on.
What's sad, isn't it, really, is that should be given throughout the country, and it's not.
Yeah, I mean, yes, that's true. I mean, I don't know about you, but I think we've made great advances in our understanding and our general acceptance by the public of mental health and mental health issues, but we've still got a way to go. So my wife and I's youngest daughter, who was actually doing an MSc in your fine institution, did one of mental health representations in the media. So she did an essay and she phoned me up. What she picked up, I won't name her in case she doesn't want to be named, but she is my daughter. What she picked up is that the media and popular culture still seems to shun, to some extent, people with severe mental ill health. So when you talk about mental ill health, it's understandable in the generality. It's anxiety, it's this, that, and the other. But the people who have these really car crashes, episodes of illness, they're still treated as, they're still othered. So I think we've got a challenge there with how we think about mental health. And we've really got to try and extend the same compassion to those people as we would for people who, you know, broken their leg or had a heart attack or whatever.
Yeah, no, I think it's a great way to almost bring us to an end. Is I think, because I think we have made progress in compassion for what we would describe as common mental health problems.
Yeah.
But we haven't made that progress with the more severe end. So, Allan, thanks so much for this conversation. Really, really insightful and wide-ranging. But just one last question, which isn't specifically on bipolar disorder, but you mentioned already that obviously you've been in this game for some time. So what maybe just ask you to reflect on is, what advice would you give your 16-year-old self? What have you learned? It can be both personal or professional, whatever.
Personally, I think I've always been very lucky. And I mean, when I was first going into psychiatry as a young doctor, I had lots of people pull me aside and say, "Oh, for God's sake, don't do that." And I remember a relative saying, "Do anything but that." And they would never explain why. So I think the message I would give to my younger self is just do what you think is best. Sure, listen to other people to some extent, but if what they're saying can't be backed up or it doesn't seem to ring true, then discount it and go with your best judgment. So I went into psychiatry and I find the whole field fascinating and rewarding, and I certainly don't regret it.
No, I think it's great advice. Well, just trust your own gut instinct, I suppose.
Well, I mean, listen to other people, but ultimately it's your life and you've got to decide.
And obviously your enthusiasm for psychiatry still, it shines through even in the podcast today as well.
Well, you're very kind, Rory.
Well, on that note, Allan, thanks so much from Craig and I for a really fascinating session, and hopefully our listeners have found this really insightful and really knowledgeable. So thanks so much. You've a wealth of knowledge. Thank you so much.
Well, thanks very much. And I may see you sometime in the Deer Green place if I'm up visiting.
You may do indeed. Goodbye.
Thanks, Craig.
Thanks.